Hello.
Hi, Doctor. Welcome.
Yes. Hi. I apologize, guys. I had to come from the hospital from another meeting. Um. Anyway, we could go ahead and get started. I'm just gonna go ahead and open. If you guys have any questions, I'll be happy to address them. My name is Cesar Santos. I'm an epileptologist. I am at Valley Children's Hospital, which is the only freestanding children's hospital in the Central Valley. We have an epilepsy surgery center, and we've been doing epilepsy surgery for maybe 3 years now. And so far, it's been going well. So I'll open the table. If you have any questions, you could just go ahead and unmute yourself. Anyone? You could also send me a chat. There is a chat button at the lower part, or maybe on the right side, depending on your screen. Okay. So maybe I could talk a little about EEG since no one has raised any questions. So most people think that when you're talking about whether someone has epilepsy or whether someone has had a seizure or not, the best, the the um, the most information you're going to get from a test is from an EEG. Yes and no. You need to understand what kind of information you're trying to get. Okay, so sensitivity of the EEG is only 50% if you're doing it the first time. And I've always said that if you're going to get an EEG, yes, it's not a perfect test. It's better to order it as an awake and sleep. Yeah, you cannot control whether the child sleeps or not, but if you could get the sleep segment on a routine EEG, the sensitivity goes up. It provides you with much more information than a, let's say, a normal awake EEG. So I've always said that a normal awake and sleep EEG tells you more than a normal awake only EEG. So it's, even if someone, let's say, truly has epilepsy and that week everything is doing well, no pressure, no stress, and you could run an EEG and it could be normal. It doesn't mean that they don't have epilepsy. It doesn't mean that they never had a seizure. If someone has had a spell last week and you're doing an EEG now, it could be normal. And again, it doesn't mean that the event that happened last week was not a seizure. So you really need to understand what kind of information you're going to get. At the same time, there are EEG, I call them EEG signatures, that tell you what kind of seizures your patient may be having. Good example is what we call 3 per second spike and wave discharges in people with absence, right? So absence are seizures where they stare. They usually stare 10, 20 seconds, usually less, and no more than 30 seconds. If a child is staring longer than 30 seconds, that's not typical absence. It's more partial, like complex partial seizures. So in those instances, if you run an EEG on that child who you think could be having absence and they are not on medication, their EEG is almost always abnormal, the first one. And then, so if you see that signature of absence, then you could say, aha, I think your child is having absence, and it tells you, one, the type of seizure they're having, and two, what kind of medication would be better. So there are EEG signatures that help you decide what kind of seizures your patient is having. But outside of that, sensitivity is very poor. Now, to make it even worse, you could see 2% of people with abnormal EEG and they never had seizures. So you don't treat the abnormality that you see on EEG in general. The best diagnosis whether someone is having seizures or not is really based on good history taking. So I cannot emphasize that more, so much so that if someone comes to you and said that he or she had a seizure at school, then your doctor needs to get first-hand information from someone who actually saw it and describe to you what happened from start to finish. So I think there are people coming in. No questions. I'm just here for general information. I'm new to trying to learn about EEG. So EEG, as much as I told you, is not a perfect test. That's the only test we have to date. People will tell you, well, you could draw some labs like prolactin to tell you whether the event was a seizure or not. Yeah, you could do that, but I think taking that into consideration, EEG as as not an optimal test, it's the best one we have. How often should EEGs be performed and how long in duration should they be? It depends on what you're trying to get. For example, if you are diagnosed with epilepsy, you've been on medication, you had an EEG that was initially abnormal, and now you're talking to your doctor about taking them off medication, let's say you're seizure free 2 years, then you could order an EEG because it will tell you, okay, what's the likelihood of recurrence if I take this kid off of medication? So that one would be. There is no such thing as a routine follow-up. Another instance where you would repeat an EEG is, let's say, okay, I think your child has complex partial seizure. I put you on the medication. The medication is at a good dose, yet they continue to have events. Then you may want to get another EEG. The duration, if you're trying to capture an event, obviously the longer the better. So much so that in our instance, we have an epilepsy monitoring unit where we could keep patients up to 5 days. So if I am treating you for what I think are seizures, yet you're not responding, and I know I have you on a good medicine, then I say, okay, we need to come to the hospital. I want you to be on continuous video EEG for maybe a day or two. So if they're happening frequently, then you could have an answer within a day or a few hours. If the events are really frequent, then you don't have to even do that. And you could say, okay, let's do a 4-hour EEG. So there is no such thing as a routine EEG acquisition. And the duration is dependent upon what kind of information you're trying to get. Um,
I have a question, doctor.
yes.
So a follow-up to my first question is, so my son had his first event as a nocturnal seizure on 1/2/2020.
Okay.
And he had a 40-minute EEG. And so I just wonder whether the information from that is enough to I guess I'm just confused because he's had one event and then we were given the option to based on that, we had to basically fight in order to get an EEG, and we got an EEG and it had some very interesting information. It was 40 minutes. He did not sleep. And then he had a normal MRI. And so initially he was diagnosed with BRE, and then 6 months down the line, now it's really not BRE, but they don't really know. He had a second event in April, another nocturnal seizure, same time. and same time in the morning. And now I'm just kind of wondering, was that a long enough EEG? Do I need, because it's not that I just want to make sure that he's well controlled. He's now on medication, but was that a long enough EEG? Should it have been a little bit longer to record more? Should we have tried to get him to sleep to understand what those sleeping brain waves were doing? Or should I just be happy that he's well controlled right now on Keppra and just be quiet and hope for 2 years seizure free?
No. Those are all good questions. So I'm going to go back a little, okay? So if you know 100 people, which I know you do, from age 1 to maybe the time they leave the earth, 10 out of 100 will have a single seizure in their lifetime. So 10%, right? The good thing about the 10% is only 30% will have a second one. So going back to your first one, had a seizure in January, and having seizures at night is not unique to anyone. Our brain's tendency to have seizure is highest when we are asleep. Some stages of sleep more than others. There are patients with truly diagnosed epilepsy that only happen at night. There is actually a condition called nocturnal frontal lobe epilepsy. So it's a frontal lobe seizure coming from the front of the brain, and it only happens at night. And it's autosomal dominant, meaning you have strong family history. Anyway, so EEG the first time, 40 minutes, which is a standard, normal, abnormal, even if it's abnormal, okay, it may tell you, okay, the seizure probably was partial because I'm seeing only abnormalities on one side.
It was.
Then that tells, right, and then that tells me, especially if you mention if it's BRE, then that tells me if I have to put that kid on medication, then I know I have to focus on partial medicine. Now, BRE, remember you heard me say that there is a signature EEG abnormality in some people. Benign Rolandic is one of those epilepsy that has a signature on EEG. If you see that signature, then you say the seizure sounds like BRE, the EEG looks like BRE, then this patient probably has benign Rolandic epilepsy.
But
now,
his EEG doesn't look like
right,
that.
so now it looks like it's changed, so they don't know, right?
Right.
So more likely, I don't know what your EEG, your son's EEG look like. It's probably partial EEG, partial. It's probably not benign Rolandic, right? And he's on Keppra. Keppra is a good medication. So your EEG is abnormal. It's only 40 minutes. He didn't sleep. He's on Keppra now and not having any seizures. I don't think you need to worry about the EEG.
Okay.
Okay. So you start questioning about the EEG when, so 70% of kids will outgrow their seizures. 70%. Okay. So 2 years from now, your neurologist or his neurologist is going to talk to you about, okay, I think we now could talk about the possibility of weaning your child off of medication. I'd like to see another EEG. Then I'd say, yes, let's get another EEG. Because if it's normal, I'll be able to tell you your son's EEG is now normal. Yes, it's not 100%, but it's less likely to recur when I take you off. But remember, you're starting with the outgrowing seizure at 70%, which is pretty good.
Right.
The good thing about benign Rolandic epilepsy is the name. It's benign, although some people will argue that it's not benign. But 95% of kids with benign Rolandic epilepsy, 95% will outgrow it. Okay, so it would be nice if you could actually look at an EEG and say, this looks like benign Rolandic epilepsy. Can I ask you what your son does when he has those two seizures?
He has, it's kind of, I'm not sure if it's signature tonic-clonic because he doesn't do a lot of jerking, but he tenses up and he like a choking sound and drooling like that for about a minute in duration.
Does he complain to you at first? Does he know it's coming?
No, he's sleeping. It's
He's
5
sleeping.
a.m. was the first one and 5:30 was the second one. Luckily, he sleeps with us, so he was in my bed.
But he
both times.
didn't wake up at first feeling like he was choking.
No, he was asleep,
Was
dead asleep.
Was he grabbing his neck when
No.
he had a seizure? No. Okay. there are some seizures, clinical semiology, meaning the description of seizures that tell us where it could be coming from. People, for example, who are drooling and feel like they're choking, that's a typical seizure for what we call insular epilepsy, meaning it's located in the part of the brain we call the insula. But again, your child is seizure free. Last seizure is in April.
Correct.
On Keppra. I don't care what the EEG shows at this point.
I like
If
that.
my son is seizure free, right? I'll say, okay, fine. Let's continue with the medication. You're not having any side effects. You're not having any seizures. Let's talk about EEG 2 years from April.
Okay. All right. Thank
And
you.
that's different. That's different if he starts having more
Right.
seizures, right? Okay.
Thank
Does that
you.
answer your question?
100%. Thank you. I appreciate it.
Perfect. Good. Thank you. Oh, you were in DC, right?
Hi, so this is Sarah. This is a different one, but I'm in DC, yeah.
Oh, you're in DC. You're at this Children's. I was at Georgetown
Oh, okay, very cool.
before I moved here 4 years ago. Anyway, go ahead, Sarah. What's your question?
So
It was very unusual. Okay.
yeah, I attached the EEG for you because I just happened to get it today from Walter Reed. And I talked to the doctor that read it, and he said that it's very unusual. We can actually cause her seizures by startling her, so loud noises, moving quickly, touching her if she doesn't know that we're going to.
Yes.
And they referred us to Children's National. So we'll be seeing Dr. Gaillard.
Yes, good.
On the 16th. She's currently not medicated. Can you get her? And she has anywhere from 20 to 40 of these a day, and then also at night. I was just curious if you had seen an EEG like it before, because when we talked to the folks at Walter Reed, they hadn't seen anything like it before.
Well, I not knowing what the EEG. Oh, is this your EEG?
Yeah, I attached it.
Okay. Startle EEG. I'm going to see whether it's going to let me see it. Open file. Okay, so startle EEG or startle seizures, we call them reflex epilepsy, right?
Mm-hmm.
And it's not unusual, but also not very common. I'd say maybe 3% of all epileptics are reflex related, either sound or bright lights. And that's why, if you see now on games, they have a warning on all of them that says, this could cause you seizures. And that only happens in about 3% of epileptics. So there is such a thing as a reflex epilepsy, whether it's due to noises or sound, and usually it's a combination of both.
Mm-hmm.
How old is your?
She's 16 months.
16 months. Yeah. There are specific syndromes that need to be looked at, genetic testing, I mean. Because early onset epilepsy, number two, and it's reflex related. There are epilepsy conditions, genetic conditions that could be causing that. So I think, and you're seeing the right person at Children's National, Dr. Gaillard, because that's what he does. And how long has he been doing this?
So we think it started right around 12 months. So the last 4 months maybe, but we thought she was jumpy at first. And then we realized that it wasn't just jumpy. There were other things going on.
Yeah. And is he losing ground, losing milestones?
No, not at this point, no.
That's good information. I'm glad to hear that. And you've seen a neurologist or going to see Dr. Gaillard?
We saw a neurologist at Walter Reed. Yep. And
who did you see at Walter Reed?
Dr. Young.
Yeah, Dr. Young. Okay.
Yep.
Because he's the only pediatric neurologist there.
Yep.
Yeah, I know him. I know him well.
He's a great guy.
Oh yeah. I cannot open your EEG.
Oh man.
I've been trying. I downloaded it to see if it's going to let me open it, and it's still here. Open file, download, save. Okay, hold on. No, hold on. Anyway, any other questions while I'm trying to see if I could open this? Huh. Desktop. Cancel. All right, I think did you just take a picture of this EEG?
So there's no way to get an EEG out of Walter Reed, period. So Dr. Young took a picture for us.
Well, this is a generalized spike and wave. Parent made a noise to provoke the episode, and then when you made the noise, what did your daughter do?
She jerks and her eyes roll back.
So big jerk.
Yeah.
Whole body jerk.
Mostly. So if we do it normally, if it happens at home, it's her arms jerk anywhere from like 1 to 4 times. She loses. She bends forward slightly, and her eyes roll back.
So you could look at myoclonic epilepsy
Mm-hmm.
In infancy, and that's gonna educate you more as the type of things that I'm not saying you need to do that and try to diagnose your child because you're going to see Dr. Gaillard, right?
Right.
But
Yeah.
it's just going to put you in a better position to ask the right question. I'm looking at the EEG here. This is as described, generalized spike and wave discharges. And I won't be surprised if after maybe 100 milliseconds after this EEG abnormalities, that's when the myoclonic seizure occurred.
Okay.
So most startle seizures are what we call myoclonic seizures. That's why I ask you to look at myoclonic epilepsy of infancy.
Mm-hmm.
And there are gene tests nowadays, thankfully, that would not only tell you the proper medication and the diagnosis. Yeah. And
Great.
myoclonic seizures tend to occur in clusters like that, not just one at a time. They come in rows.
Is this you said kids 70% will grow out of it? Is this something that's normally grown out of?
In general, okay, there are benign myoclonic epilepsy of infancy.
Yeah.
But there are also myoclonic epilepsy of infancy that are not.
Okay.
And not knowing where she falls, I won't be able to answer that question for you.
Okay, that makes sense.
Yeah. Can you explain the difference between or the clinical significance of background slowing and epileptiform discharges? Okay. So, that was Andrea. Okay. So, when we look at EEG, it's a brainwave activity test, right? So it's electrical activity test of the brain. It's not a pictures test. How I explain it, if you take an MRI, let's say you're looking at the house, you're outside the house, you get a picture of the house, you know, the roof, the siding, the color. That's an MRI that's going to give you. And MRI is better because you could actually even see the inside. But the MRI doesn't tell you the plumbing. It doesn't tell you the electrical connections. The EEG tells you the electrical connections in the house, whether it's at fault. So you could have, let's say, it's raining outside and you're like trying to connect to your internet and it's slow. Background slowing on EEG could be as simple as that. If you are sick, you're dehydrated, you're taking steroids, you are you have fever, you're on some other medications, your EEG could slow down. So we have set numbers that we count per second of the number of waves that your brain generate, and then we compare that to what we call normal values. And in babies, it's hard because they change every week. And so if it's slower than that, we say it's background slowing. It doesn't really mean anything. It could be due to a lot of things, which I mentioned already. You're dehydrated, you're sick, you're on steroid, you're taking some other medication, or you're having frequent seizures. You're having frequent seizures could slow your brain activity down. Now, epileptiform discharges are the abnormalities we see in people with tendency to have seizures, and we call them sharps or spikes. The sharps, they become pointy but not too pointy. The spikes, they're really, you know, like spires of churches. And like I said, they are abnormalities we see in people with tendency to have seizures. You could be epileptic and have a normal EEG. So, and when we talk about having spikes, it doesn't mean your child is having seizures unless we dictate it as such. If you have, let's say, a child who had a stroke in at birth, so you're going to have a scar tissue because of the stroke, right? If I run an EEG on that child because the stroke has created the scar tissue could create sharps and spikes. So me knowing that your child has had a stroke and has scar in the brain, I will not be surprised to see the sharps and the spikes. Would I put that kid on medication just because of the sharps and the spikes? No, if you don't tell me that you're suspecting that seizures are probably happening, because you will never know when you need to end giving that child medication. You just have to keep on getting an EEG and hope that the next one will be normal. So the spikes and the sharps are epileptiform discharges that we see in people with tendency to have seizures, but not everyone with sharps and spikes have epilepsy. So you have to put the history and the EEG together and use it with good history taking. If, let's say, you just had a seizure an hour ago and then we put you on an EEG, your EEG could be slow. And then if I let you rest and you recover in an hour or two, I do an EEG, the slowing may be gone. So slowing on EEG doesn't really tell you a whole lot because it could be to a lot of different things. What do we need to know as parents when looking at our child's EEGs? Well, so it depends on, again, when the EEG was done and what kind of information you're trying to get. If your kid is really having a lot of spells that are worrisome for seizures, it would be nice to run an EEG that's long so you could capture the event on EEG, and then so your neurologist would be able to tell you, is this what you're looking at home on the one I recorded on video EEG? And parents say yes, well, that's a seizure. The brain activity looks like this when he's having one. Or that child may be having 2 or 3 different kinds of events, and you record the second type and you say, okay, does this look typical of event number 2? This one is not a seizure. So that's when you need to know what kind of information you're getting. And also takes me to the earlier question as to what's an appropriate one, a 40-minute one or a long one. It depends on what kind of information you're trying to get. If you're trying to get to capture an event that's occurring frequently and they occur once every day, then maybe a 24-hour study. I am Sora Aurora. I do not have a PowerPoint because we were told that it's not necessary, and it's want it to be as relaxed and conversational and open. But that's a good question. I think I have gone through all these questions. Yeah.
I have another question, doctor.
Yes.
If a child is on medication for a prolonged period of time, is there a chance that a clean EEG would be due to the medication?
Good question. And a lot, if not all, parents ask that. Okay, so you do another EEG, and then the parents say, "Well, it's normal now. Is it due to the medicine?" Yes and no. And that's why it's important to know what kind of information you're going to get when you order the EEG, right? So remember I said if your child is having absence and not on medication, that EEG is going to be abnormal. If I put that child on medicine for absence and the absence seizures go away clinically, and then I do another EEG, that EEG could be normal. You see? So that means what I'm doing, the medication I'm giving is really responding on 2 counts, clinically because the parents have not seen any seizures, and 2, the EEG has normalized. So yes, it could be a good information. Complex partial seizure are a different story, or partial seizures are a different story, because I told you already I could be abnormal this week and normal the next week, even if not on medication. So if you're asking me, well, the EEG is normal, he's not having any seizure, could be from the medication. Yeah, sure. But again, I'm going to go back to the fact that your child does not have a seizure on medicine. And then come 2 years, we'll talk about what we need to do. So it depends on the context.
So basically, no matter what, once you get to that 2-year seizure free and you kind of have to cross that bridge, no matter what,
Yes.
you're going to be kind of like with bated breath trying to figure it out.
Well, with the help of your neurologist, you'll be able to decide. Okay, and it becomes, this is what I do with my patients. Okay, I said, okay, fine. I told you already, 70% will outgrow it, but we need to watch your child and get a 2-year seizure-free period. And then I'll sit down with you. Before then, we'll get an EEG, and then I'll sit down with you with the EEG and give you numbers. Okay, so your EEG is normal. Let's say, okay, your EEG, you had one seizure. Your EEG is abnormal. I do not know why, because I do not have any good history as to why you would be having seizures. So that's your idiopathic. The likelihood of you having a seizure if your EEG is abnormal goes up from 30 to 48%. So if I know you had a stroke and now you had a seizure and your EEG is abnormal, the chance of you having a second one goes up from 48 to 60. So the EEG tells you a whole lot more, but you need to use it in the right situation. In an idiopathic case, you're seizure free. I don't do, let's do another EEG. No, I don't do that unless you're having breakthrough events or my medication doesn't seem to be working. But if you're seizure free, I'll see you next year. And then 2 years from now, we'll talk about taking you off and repeat another EEG. Yes, Matt, you have a question for us?
If you were talking to me, no, actually, I didn't have a question. I was getting a text.
Okay. All right. So there is another one here. What is helpful for you as a provider for parents to bring in their appointment? Very good question. Oh, I didn't mean for you to turn off your video, Matt. Whenever you're going to see your neurologist, whether it's the first time, you try to get as much information as possible. If, for example, you've had an imaging study, an MRI or a head CT, it would be best not only to bring the result, a copy of the result, but go ahead and secure a CD copy of the imaging study. Because we have to rely on the interpretation if you don't bring the actual CD for us to review. EEG is very hard to transport. There is significant limitation between software that even if you do an EEG next door, our EEG software may not be able to open it and I will not be able to read it. That's why in most instances, if you see a neurologist and you've had an EEG outside, we often would say, I would like to see one here. And I would like for you to come back here so I could see it. If you're seeing another neurologist, that's really more important for you to bring all of them, including genetic tests. Not just the result. If you could bring with you the actual study in a CD, if you could bring with you, if they're going to allow you to bring EEGs on a CD, please do it. Not, you could do, snap shots of EEG, but unless it's like this, that's really abnormal, it's going to be hard to read. So that's the best thing. And then always, sorry about the noise, always bring a description of the events from the person who witnessed it. So if it's from the school, talk to the teacher and say, okay, can you describe to me from the start what you saw? And you could also do some testing at home. If your child is having events, you could talk to your child and ask them to do simple things. What's my name? What is this? Can you look up, look right, close your eyes, stick out your tongue, and see if they could follow. Or ask them to say something, see if they could talk during the seizure, because it tells us whether it's from the left or on the right. And actually, you know what? This day and age, it's always better if you just, I know this is hard, especially if your child is having the first seizure, to think about pulling your phone and taking video. But taking a video of the event is very helpful. Yeah, a lot of the times parents now say, can you describe to me an event? Well, actually, I have a video for you here. That's very helpful. So I would add that to your question, Caitlin. Bring a video if you have one. And if you don't, try it before your next appointment. I'm just going to go close my door, but I'm still here. Let's see. All right. See, it says here, no one believed us until I had the video. Yes, I know how often that happens. We've seen kids here who have been having events for years and years and been called so many different names until a video was produced. And that's why it's important, if you are not sure, to bring them to the hospital and record the events. We do that quite often before we say, okay, I don't think your child is having a seizure. I actually give the benefit of the doubt rather than saying I don't think it's a seizure. So here's a question from E. Our child, 3 years, has been on a ketogenic diet for 3.5 months after 3 EEGs, 1 abnormal MRI, and 4 medications. We did not see any benefit from the medications and had adverse effects with Keppra. Our neurologist still has us using topiramate. At one point, would you expect another EEG, an atonic, drop seizures, refractory epilepsy diagnosis? Okay, so 3-year-old abnormal MRI. Can you tell me, if you could, what the abnormal MRI means? What did they see? And the 4 medications. So I have 2 here, Keppra and topiramate. What are the other 2? And I guess you're telling me that the type of seizure is atonic, which is the drop seizures. Any other type of seizures or just the atonic? This is where I would say you need to go see a neurologist who specializes in epilepsy. It's now, if you look at, remember I said earlier, 70% of kids will outgrow their seizures. If you start someone on medication, 65% of the time, you're going to be able to control that patient's seizures with 1 medicine, 65%. Okay, so the number after the first medication fails, the number of people responding to medication changes gets less and less and less. So at the end of the day, I said 65% will be controlled, 35% will not be. And that's what we call a drug-resistant epilepsy. And so for me and for us to take care of kids with epilepsy, when you fail 2 or more medicines, you need to talk to someone who does epilepsy and see if your child is a candidate for epilepsy surgery. When we talk to parents about epilepsy surgery, they're scared for good reason. But it doesn't mean that your child is going to have the surgery. It just means we need to find out whether your child is a surgical candidate or not. So if your child has failed 4, and I do not know if ketogenic diet is part of 4 or maybe not, and then there is 5, then you need to go see someone. Now, you said not a surgical candidate. Did they do a video EEG and really told you that the seizures are atonic and therefore it's generalized?
Yes.
Yes. Okay. So
we saw our neurologist in our town, and we traveled out of town to a children's specialist and to look at surgical options, and they said he's not a candidate because of how much activity and the frequency of the seizures. Okay.
Did they talk to you about other options, like other surgical options?
I'm sorry to
Surgical
interrupt.
options goes beyond resection. So the most common surgery that we use for epilepsy surgery is temporal lobe surgery, temporal lobectomy. We take out the temporal lobe or part of the temporal lobe because majority of the partial seizures are coming from there. But that's not the only option we have. So for example, if your child really has atonic and it's all 100% atonic where they drop, right? So there are atonics. I've seen atonics where they drop from standing and face down and or sitting, and then they drop, so they hurt their face, and so they have fractures on the nose. There is a surgery we do, we call corpus callosotomy. So you have this corpus callosum that connects your left brain and the right brain. So it's like the interstate.
Yes.
Right? For people who have atonic seizures, that takes care of the atonic, the corpus callosotomy. You cut the corpus callosum in two, so the information doesn't cross the other side. And you may not be seizure free, but one atonic seizure a day or one atonic seizure every few days is a lot, just because of the implication, right, of dropping and hurting yourself. But if you could minimize those atonic to maybe one a month or even less with corpus callosotomy, I think that would be a worthy consideration to talk about. It is not a surgery designed to control 100% of the seizure, right? Because you're just disconnecting. You're not taking out really the where the seizure is coming from. But if, let's say, you have two types, partial seizures that happen 3 times a month, and you have atonic that happens 2 a week. If we do corpus callosotomy and we take away all your atonic, your child will be a whole lot better having 3 partial seizures a month and no atonic. I'll take that as a parent. So I think your neurologist may say you're not a surgical candidate for a resection. Then you could talk to them. Well, okay, fine. If these are really atonic, are there any surgical treatment that you could, like VNS, for example? I don't know if you talk to them about VNS.
We were referred for VNS, and they said
Right.
there was so much abnormal brain activity. They could not isolate where in the brain the seizures were originating from. And so my main question is, are the EEGs just a checkpoint to see, okay, how are we doing? Are they increasing? Are they decreasing? So that you can see that data? Or is the EEG just to verify, yes, this is seizure activity, listening to your other conversations? So,
well, both, right? So to me, for your child, my main issue is, if the clinical seizure sounds atonic, does it look atonic on EEG? There is an EEG signature for atonic seizures. And are all your seizures atonic, which is, it happens, but not very often. Okay, most of the time when you have atonic, you have different types. You have other kinds of seizures. But let's just say, okay, I have an EEG, and all the seizures I have captured are drop seizures, like atonic drop seizures, and the EEG looks like drop seizures. So, okay, fine. I'm going to talk to you and say, okay, this is what we're dealing with. One, yes, atonic seizures are very difficult to treat. 2, they're not amenable to resective surgery, but they could respond very well to corpus callosotomy, and they may respond to VNS. The issue with those 2 surgeries that I mentioned is not like resective surgery, where I could say, okay, I know where the seizure is coming from. We could take it out with very minimal, with no deficits, and there is a likelihood that your child could be seizure free 65, 70, 80%. In cases where it's atonic, and we're talking about corpus callosotomy or VNS, corpus callosotomy could take away all your drop seizures. I have seen that, where they have other seizure types, but because the one that hurts them are the falls, if I could make them seizure free from the atonic, it's still a big improvement. They're not dropping, they're not hurting themselves. I have seen kids 100% no drop seizures from corpus callosotomy. For VNS, the best number people should be giving you is, if I could drop your seizure frequency by 50% half of the time. So in 100 kids, if they're all having 100 seizures a day, in 50 of those kids, I could drop their seizures by 50. Again, if you're having 10 seizures a day of drop, and I told you I could make it better 50% of the time, 10 drop versus 5 drop would, to me, would still be a good surgical outcome. Now, could you do better than 50%? Yeah, I mean, if you look at the data with the VNS, the numbers of people having good response to VNS goes up every year. We have data all the way to 3 years, and we're hoping that there would be more data from the company moving forward, especially with the new VNS system that we have. So I think, based on your information, I would agree she's not a surgical candidate for resection, but maybe a surgical candidate for VNS or corpus callosotomy. Now, on ketogenic diet, what's the ratio? 3-to-1, 4-to-1?
We're on 4-to-1 right now.
And what's your ketone bodies? High, medium, large?
We are about 3 to 4.
Okay, well, that's pretty good. And what's the other 2 medicines besides Keppra and topiramate?
Clobazam, and I can't remember if that's the brand name or not. I don't think it's the brand
No,
name.
that's the generic. Clobazam brand name is Onfi.
Yes, Onfi, and I cannot remember the first one we tried.
Has it been tried on Depakote?
Depakote, yes.
Okay, so you've tried. How about Lamictal?
No.
No. See, Lamictal would be a good choice. How about CBD, Epidiolex?
I've briefly mentioned it, and we haven't gone down that road.
Yeah, that would be
Our
another good one.
neurologist said that we might not have. She doesn't believe there's enough research on that yet to. But we haven't completely ruled it out yet. So.
The Epidiolex, I could tell you we've got good response with Epidiolex. So Lamictal, Sunisimide, Epidiolex. You have 3 more choices to go to.
What was the second one you said?
Sunisimide, Zonegran, Epidiolex. I would probably. So you're on Onfi, Keppra, topiramate, and ketogenic. Can I ask you how much Keppra?
We're not on Keppra anymore. We are only taking topiramate because we had adverse side effects.
Okay, well, that's good. That's good. I like minimal medicine. The most medicine I have is 2, maybe 3, where I'm transitioning you to another one, because you end up having more side effects the more medications you have.
We've only been on 2 at a time, but we're only on topiramate.
Yeah, that's good.
Right now.
Good. So I think Epidiolex would be my next one, and then Lamictal. Lamictal is good. It's just it takes a long time to get up to a good dose. That's why I say Epidiolex first.
Thank you for your information.
Oh, you're welcome. Anytime. Where are you? Can I ask?
I'm in Boise, Idaho.
Boise, Idaho.
Yes, and we went to Seattle for our Seattle children.
Yeah.
I've really appreciated our team.
Good.
Because we have 100 seizures a day.
It's the problem with Atonic. They come in clusters.
Yes.
Yep. Your epilepsy gene panel is normal?
We have one that we're getting further information on.
Okay.
We had 3 that they looked at, 1 that they ruled out, 2 that they're going to do a parental genetic panel.
Okay. Well, good luck to you.
Thank you.
If you have any other questions, you could send me an email.
Thank you so much for your time. This has been very insightful.
You're welcome.
Dr. Santos, we have our next.
Hope you get better control.
Thank you very much, doctor.
Drowsiness, sleepiness are side effects that I have seen due to medications. Plenty. So there is a question. Can I still answer this?
Sure, go ahead, doctor. Finish
Okay.
this one up.
So it says drowsiness and sleepiness are the side effects that I have seen due to medications. Are there any other side effects to look out for? Yes, there's plenty. But you have to realize that there's no medication out there without side effects, right? Yet we use them every day. I mean, a good example, aspirin, Tylenol, Motrin, Aleve. We take them like, vitamins. There's no tomorrow. They have plenty of side effects. So when we talk about side effects of medication, you have come to a decision. So if this is a seesaw and the balance is in the middle, you have to be able to tell yourself that the side effect that I could get from the medication is less than the benefits I could get, right? So, but it doesn't mean that I put you on the medication and you're having so much side effects, I'm going to ignore what you're saying. No, there has to be a good balance. A perfect balance would be seizure-free and no side effect. That would be nice. But there would be a balance where you're seizure-free and you have very minimal and tolerable side effects. And you could get around that if you actually know what you're doing. And that's why I mentioned I try not to use more than 2 medication, and I don't try to change medicines too often and too frequently, so I don't learn from what I'm doing, because you end up having side effects and you're like, what happened there? What is it because I changed it so rapidly? Is it because I added this one? So drowsiness and sleepiness, you could see that practically on all of them, especially when you're starting new and fast. Some are weight positive, some are weight negative, like Depakote, you tend to gain weight. Keppra, you tend to lose weight. A lot of them have GI side effects. You get nauseated, you throw up. Some are appetite suppressant, some are appetite stimulants. Some will make you sleepy, so it may be good at night. Some may prevent you from falling asleep. Some have behavioral issues, which is very common. So,
Very much, Dr. Santos. We really appreciate it.
anytime.
Thank you very much.
Good luck to you guys. Hopefully I was able to answer your
It
questions.
was amazing. Thank you so much.
Thank you.